Yes, good evening, ladies and gentlemen. Thank you for the nice introduction. Dr. Saeed, thank you for the organizing committee. Thank you for the scientific committee for organizing this series of webinars. This series of webinars make it easy for me to make my one of my dreams to come true even virtually, which is a multidisciplinary team approach to chronic pain. So from there, the objective of this of my talk is to give you an overview of concepts of chronic pain management. The objectives mainly comes in from defining and understanding the fundamental concepts of chronic pain, explore the underlying physiological and psychological mechanism that contribute in chronic pains, identifying common risk factors associated with chronic pain, analyzing the impact of a chronic pain on individuals' daily function, and coming into the approach of a chronic pain management for these patients. Next slide, please. I don't have anything to disclose except that sometimes I prescribe narcotics for my patients. Next. The key concept is to understand chronic pain and its effect and to become familiar with the treatment options. Next. So chronic pain is very common. Pain in general is very common. Most of our patients come to us is basically because of pain, pain from the head to toes. Nobody will come to seek a primary care physician or emergency because they have a high blood pressure, usually it's silent, or have high diabetes, unless it's an emergency. Usually, patients will seek healthcare if they have any types of pain anywhere in their body. Next. So pain is very common. WHO showed that pain is ranging from 20 to 30% in one study. A National Institute of Health publication stated that chronic pain is the third largest healthcare problem in the world. So we should consider chronic pain as a disease by itself. Cross-sectional studies in Sweden shows that the prevalence of pain is around 49%, and the chronic pain in general is 54%. And also, chronic pain is a costly. In one of the American studies shows it may cost around 50 million. It causes disabilities and it causes a financial impact on the healthcare system. Also, it counts around 80% of physician visits are related to pain, as I said previously. Next slide. So chronic pain usually happens because of the acute pain. Acute pain could be due to surgical, medical problems, or trauma. And the pain usually is moderate to severe. This untreated acute pain can lead to unnecessary suffering, prolonged hospital stays, increased medical costs, and progress then to a chronic pain. So the most important thing is really to break the cycle of continuous acute to chronic pain and the factors that makes patients end up with a chronic pain. Next slide. So in studies that shows the impact of pain as a disease, unfortunately, as we grow, the pain is increased. So then the chronic pain increase as we grow. And surprisingly, it shows that women have more chronic pain complaints than men. Next slide. Um, and among different types of pain that being reported in one studies, the most common type of pain is cancer pain, is palliative pain, uh, neuropathic pain, and we will go through the difference between different types of pain in minutes. Back pain or cervical pain, arthritis pain. And there is different cost of that depending on pain. So pain with all different types is really costly. Next. So, even without these statistics, in my practice, and I think if we have a primary care physicians here with us, we know that back pain is the most common pain that we can see among all patients. Not only the most common pain, is the most common complaint that we can see as a primary care physician or an emergency practice. In my practice, most of my customers come from orthopedic and neurosurgery and then internal medicine, like rheumatology cases, and then also surgical cases. Also, definitely headache is considered one of the most common pain problems, cervical pain, and then facial pain. Next. So, since we are talking about pain, um, do we have a definition for pain? Um, it's if we think deeply about it, pain is really subjective, and it might be variable from one person to another how they define pain. So yes, there is a definition for pain. Next slide. So the International Association of Study of Pain define pain as unpleasant sensory and emotional experience associated with actual or potential tissue damage. So it is sensory and emotional experience. So there might be also a damage or potential damage. So the definition itself is complicated as the topic it is. Next slide. So, studies shows that pain can be influenced by certain factor and intensified by certain also factor. So there is culture factors. All of us know that certain cultures they can express pain or experience pain different than other cultures. Also, it's different how we express pain from gender point of view, the contents, our previous experiences, even from childhood as infants. If one study shows that infants who stayed in incubators with a lot of pricking while they are incubators, prematures experience pain differently than mature infants with normal deliveries with no other risk factors, emotional and cognitive factors. And I think my colleagues in psychiatry will explore more on this topic. These things are intensified by other factors like the feeling of fear, guilt, anger, loneliness, and helplessness. Next. So the cycle of uncontrolled pain and fear will make the cycle of pain, patients complain more of pain. Understanding this is really important. So there will be pain, fear, avoidance behavior, and more fear, decreased mobility leads to altered functional status, diminished self-efficacy, and then more social limitations and more pain. And the cycle will continue. Understanding this help us to stop the cycle and interfere at different levels with different modalities. Next slide. So, as a healthcare provider, we learned how to divide problems into a simple way of thinking. So, to make it more simple, pain can be divided in general into an acute pain and then chronic pain. And then the chronic pain itself can be divided into a cancer pain and then non-cancer pain. So the definition is important in terms of in management. So if we are treating acute pain, then we will go more into an acute pain management, shorter duration medication, faster effect. And we know that these patients will not be continuously on pain medication. Also, if we differentiate between chronic cancer pain and the chronic non-cancer pain, will make us um, feel easier in management of and for, it's true that cancer patients they are more miserable but usually we are not worried about other factors like addiction with those patients. The most important aim with cancer patients is to ease their pain and usually addiction is not a concern. I think the most difficult patients among them all is chronic non-cancer patients because usually they are healthy relatively. They can live long life, and they can live in long-term pain medication. Next slide. So as I said, acute pain present most often with a clear cause, either surgical, medical, or trauma, relatively brief in duration, usually less than 3 months, subsides as the healing take place, and accompanied by observational objective signs of pain, like increased pulse rate, increased blood pressure, nonverbal signs and symptoms such as facial expression, tense muscles. And usually those patients are more anxious rather than depressed. Next slide. Cancer patients, patients that the pain that is usually associated with cancer or cancer treatment, like chemotherapy or radiation therapy, and may be attributed to the tumor location itself, like compression for example, in a spine or an organ. As I said, chemotherapy, radiation therapy, or post-surgical treatment. Next slide. While chronic pain syndrome can be defined pain that lasts more than 6 months, some definition says it lasts more than 3 months, associated with depression more than anxiety, and also can associated with other factors like anger and fear, restriction in daily activities, excessive use of medication and medical services. In my practice, I see referrals of patients that have been seeking health care facilities inside and outside the countries, and they are in multiple medications, narcotics and non-narcotics medication, and also psychiatric medication. They've been going through multiple non-productive tests, treatment, and even multiple surgeries. And there is usually no clear relationship with the organic disorder. Next slide. But the definition really I like, and it makes it easy rather than we count days or months for chronic pain. It's the pain that persists beyond expected period of healing. For example, if there is a fracture in one limb, we expected that limb to heal within 6 weeks. If it lasts more than this, and the patient is still complaining and need to have more medication, then we have to reevaluate that. And definitely, it's variable from one surgery to another surgery. Next, a little bit of physiology here. So, what makes a pain chronic in nature? So, if there is an acute injury due to surgery, as we said, or inflammation or trauma, there is activation of the peripheral nociceptive fiber. If the trauma or the pain gets sustained, there is more activation of these fiber, and definite then it will lead to what is called CNS neuroplasticity and hyperactivity, and leading to chronic pain. So understanding these concepts help us to understand the importance of stopping the cycle of continuous acute pain. Management of acute pain early with early modalities will prevent eventually chronic pain. Next. Also, there is another definition. We divided pain according to the duration into acute and chronic pain, and according to the cause, cancer and non-cancer pain. It is also important to differentiate between two categories of pain according to the symptoms or presentation that the patients have: neuropathic and nociceptive pain. And why is that? Because the management and the pharmacological treatment specifically for a neuropathic pain will be different than nociceptive pain. And I will leave that to my colleagues, that the details of that to my colleagues that will discuss pharmacological treatment. Usually, patients with a neuropathic pain will present with pain that is burning, stabbing, and electrical shock sensation. And there is certain symptoms that we call it allodynia, hyperalgesia, anesthesia. So this is the symptoms that patients will present with. So they will say, I feel more pain in this part or this of my body that is unusual, like a simple touch. I cannot tolerate any clothing on my body. Water bother me. I feel electrical sensation. It burns like bill paper, or it burns like fire. Or they lose the sensation completely. So these are the symptoms of a neuropathic pain. While what is called nociceptive pain is the pain that is usually due to inflammation or musculoskeletal pain. So patients usually will complain of tenderness, acheness, stiffness. They will say that I have pain, that aching, sharp pain, like a toothache, for example. This is nociceptive pain. And then, of course, patients can have both combined, both the neuropathic and nociceptive pain. Next slide. This is a famous slide that you can see in all the presentation that talks about chronic pain, and it's from the International Association of Study of Pain that differentiate between those type of pain and what is the type that can be combined or mixed type of pain. For example, low back pain can be both nociceptive due to inflammation or degenerative disc disease, and the neuropathic when there is a nerve involvement or radiculopathy. So those type of patients can be treated both with medication that is for both nociceptive and the neuropathic pain. While patients who are complaining of a purely neuropathic pain, such as diabetic peripheral neuropathic patients, which is very common, patients with trigeminal neuralgia, post-herpetic neuralgia, those we should treat them purely with a neuropathic pain medication. And patients with purely nociceptive pain should be treated for inflammation, pain, osteoarthritis pain management, post-operative visceral pain, which is one of the most difficult type of pain, the visceral pain. Next slide. So I'll go through a quick overview of chronic pain management, and the details will come later in with my colleagues. Next slide. So generally, usually I like to have more interactive lectures, but I don't know how to make webinar more interactive. Um, uh, I'm sure all of us attending 1,000, more than 1,000 attendees attending this lecture because they are interested on pain management. And it is really difficult because it needs a lot of understanding and it is really subjective to measure pain or to assess pain. So in general, pain management is poorly understood, poorly managed in the society. Next slide. For many reasons, for multiple reasons. Um, one of the reasons is the culture and the regulatory bodies, availability of medications, the teaching, us as a healthcare provider, from physicians to pharmacists. I don't think we went through this subject in our studying very thoroughly. Also, the regulatory bodies are putting a lot of restriction and availability in pain medication. All of us at different levels, we are fearing of addiction, and we are not sure how to prescribe medications for this patient, and who are the patient that we should prescribe for them, and for how long. Patients themselves also, they can be risky, or themselves also they can you'll be surprised, most of our normal patients will be afraid from addiction. Our patients, they are afraid to get dependent on antihypertensive and diabetic medication. What about other medication? These are the normal patients I'm talking here, that they don't have risk factors for addiction. So patients themselves, chronic pain patients, they have these concerns. They feel that they are not believed, they are not heard, accused of addiction. They feel abandoned and alone. Next slide. So as I say, the chronic pain remains undertreated for many reasons that I mentioned earlier. Next slide. So this makes International Association of Pain declare that the access to pain management is a fundamental human right. but we have to know how to deal with these patients. Next slide. And the Canadian Pain Society says almost all acute and cancer pain can be relieved, and it is important to mention, to highlight the word relief, and many patients with a chronic non-malignant pain can be helped. And this is important to understand. Next slide. So the most important concept in pain management is to be realistic. The aim of pain management really, and we should make this clear with our patients. Uh, Persistent pain is multifactorial, and persistent pain is treatable with improvement of quality of life, but it is not curable. So the most important goal in pain management is to improve the quality of life. We should consider underlying conditions, patient comorbidities, as we said earlier, comorbidities, medical risk factors, and psychological risk factors. Increased potential for drug and drug disease interactions, environmental factors, physical, psychological, and economic factors. And the aim is to maximize function and the quality of life, as I said, to minimize adverse effects that may be associated with the treatment. Adverse effects on the patient themselves and on the healthcare system and on the society. Next slide. Next slide. So, the first important thing in the first visit, which I usually spend with my patients around 45 now with experience, it used to be 1 hour, is to come up into an agreement. The aim of chronic pain management, one, is to decrease pain, reduce discomfort by 50%. If we reach to that, on pain scale, if the patients complain of 9 or 8 out of 10 pain scale, we reach to a reasonable goal. If we reduce the pain to a 3 or 4, that is an achievement. Then improve the quality of life as physical, psychological, and social. Usually, as we said, those patients have multiple, they are usually depressed, alone, isolated, and dependent on multiple sick leaves or even retired, and they are not functional in the society. Minimizing the risk on the patient, physician, and the society, as I said. Next slide. Approach to the treatment. First of all, we should make a proper diagnosis when they come to us in pain clinic. As I said, they come from multiple referrals and they've been seeing a lot of physicians and subspecialties, but we need to reevaluate the patients again to reach into a common diagnosis, treat underlying condition and prevention, and then reduce pain, as we said, to improve the quality of life, to improve function. Next slide. Also, to emphasize that all patients must have effective pain management. But understanding what is effective pain management is not to burden them with multiple medication and aiming to reduce increasing doses and aiming to achieve zero pain with the poor quality of life. And this includes appropriate screening and pain assessment. Documentation is very important with those patients and any patients, any complex patient. So documentation is and documentation, because if you don't document, you didn't discuss and you didn't do care and treatment and pain education. And the patients have the right to self-report pain, and they have the right that we believe them. So if they say today that their pain is 8, and you think they are walking and they're happy and they're eating, this we should believe them if they say 8. But because when we start the treatment, if they come to us next visit and they say we improved or we didn't improve, if they say 7, that's an improvement. So it's 10% improvement. Next slide. Next slide. So the aim is really to reverse this cycle that I mentioned earlier to this cycle in the next slide. Next slide. So improving, remove the factor of fear and improve the quality of life by advising them to reasonable modalities of exercise, increase mobility, improve function, enhance self-efficacy, and then less pain and more functional and more and improve the quality of life. Next, if we talk about pain management, we go to the basic. There is non-pharmacological pain management, pharmacological, and then intervention. And is as in the treatment of any chronic condition, we go from non-invasive to more invasive. So the non-pharmacological pain management include physical therapy, psychological therapy, and physical therapy is exercise, acupuncture, massage, meditation, um, Tai Chi, whatever is available and make the patients feel comfortable. So patients come to me asking, what about acupuncture? There is evidence that acupuncture, it's not strong evidence, but it is evident that acupuncture can work for certain conditions. And if it's helping the patients, why not? Patients will ask me about hijama, cupping. Why not if there is no medical contraindication for that? Uh, One of the most difficult components that I face in my practice here in UAE, finding the right psychotherapist who speak the language, who can do CBT, cognitive behavioral therapy. And this is important, strong evidence that CBT, cognitive behavioral therapy, improve work with chronic pain specifically and many other chronic diseases. And now, if we speak about pharmacological treatment, we go from non-opioid medication to opioid medication. And of course, we start always with topical medication and to more invasive modalities that my colleagues, anesthesiologists or intervention radiologists can do, like a trigger point injection, epidural injection, spinal cord stimulation, and spinal infusions. Next slide. This is a WHO ladder. Usually, WHO ladder was created initially for cancer patients, but then it was modified in a such way as as in any disease or chronic disease, and specifically in chronic non-cancer pain management, it's never a one-man show. It's never one modality. We should go with multiple modalities, starting from the most important thing, which is patient self-management and education, to non-invasive modalities, non-pharmacological, psychological intervention, as I said, physical therapy, to pharmacological therapy with different levels of pharmacological therapy, from non-opioids as non-steroidal anti-inflammatory drugs, acetaminophen, adjunct medications such as antidepressants or anticonvulsant medications, to opioid therapy with different levels of opioid therapies, monitoring the risk factors of addiction, to more invasive modalities such as epidural injections or trigger point injections. Keep in mind that all of these can be used all at the same time, depending on the severity and the condition itself. Or we can go in certain patients only with intervention without medication, or we start only with physical therapy with minimum pharmacological therapy. So we should individualize the treatment plan for our patients depending on the severity and understanding of the patient. And when patients come to me, people will think that I start them on Lyrica or opioids. It's not true. I assist them and I modify their treatment plan, and usually I go and taper them from multiple medication that they are using to the minimum medication that improve their function and the quality of life. Next slide. So I think I will end my presentation here. And the aim of this webinar is to aim for pain relief and improve quality of life. I'd rather take, if there is a time, Dr. Saeed and the moderator, Dr. Um, Bal, if I'd rather take a question now, if there is time, or I will wait till the end. Thank you so much.